Well, thank you very much for this kind introduction. I'm very happy to share with you these two talks of these two important topics for me. It's a great pleasure to be, but it's a problem not being with all of you face to face. I'm so sorry about that, but the clinical situation of our countries are extremely bad. So hopefully to see you soon and to be together. So the first talk is going to be around surfactant therapy for RDS, and I'm going to focus this talk in terms of, this is my disclosure, in terms of a new philosophy related to what we think and what we are doing today about RDS. So first of all, I would like to remember you that we are very far away from those years when we were facing babies with severe respiratory distress syndrome called hyaline membrane disease. So this disease really disappeared. Now what we are facing is a new RDS problem of premature babies. Why is that? Because today we have more and more immature babies being delivered. We are giving surfactant very early. We have less invasive respiratory support from the very beginning, right? After delivery, as it was discussed in the previous talk, we support the baby's lung to increase the respiratory volume to begin to breathe and to give enough time to stabilize after delivery. Most of the babies are prepared to be delivered very immature by giving antenatal steroids to their mothers. So the new RDS is absolutely different compared to those years when we didn't have these two immature babies. We didn't have antenatal steroids. We didn't apply less invasive respiratory support. We were giving very aggressive resuscitation, and we didn't have surfactant therapy. So today the picture is absolutely different and clearly represents immaturity of the whole baby. But still, even if you apply enough pressure and you help the baby to begin to walk, to breathe after delivery, the surfactant deficiency is very typical to most of these babies. So if you don't have surfactant, as you know, you're going to have lung atelectasia, you're going to lose your functional residual capacity, and some of the lung is going to be overdistended. So take a look at this picture. This is a lung of a normal rat with surfactant at end expiration when we give gas to the lung. And if we take the surfactant off this lung, we are going to see this different situation. So this is the typical surfactant depleted lung. So of course, we can apply pressure, we can give nasal ventilation, we can give nasal respiratory support, and even we can intubate the baby and give pressure to those lungs, but you don't have enough surfactant, then the trauma is going to be triggered very rapidly from the beginning of the life of the baby. So important is to give surfactant to clearly prevent this trauma into the lung. When to give surfactant? So from many years, and these are data coming from more than 20 years, this is a Cochrane review, systematic of the surfactant use prophylactically compared to control without any kind of surfactant. And the main important benefits of giving surfactant is to prevent death, pneumothorax. So of course, we have enough information that giving surfactant, also we have data from those years, will improve clearly the survival and the risk of air leakage. Look, these are most of the studies that were using control. Today, this kind of study should be probably unethical because it is impossible to compare the result of not giving surfactant to a baby with a respiratory distress syndrome. And also, as you can see, mortality clearly decreases when you give surfactant early to the baby. Which surfactant should be given? Well, today we don't have enough data to support that one surfactant is clearly much better than the other one. From the American Academy of Pediatrics, we have the recommendation from 2014 that any of the well-proven surfactant therapies given to the babies, and really that demonstrated efficacy and safety are the one to be given. So there are not clear in terms of that. So trying to review all the studies comparing the two most used surfactant animal-derived, but they are called also natural surfactants, at least in the European Union and the United States. We did a systematic review that we published very recently to compare randomized controlled trials in the effect of the two most used surfactant, Beractan and Poractan alpha, and also we review what we call the real world studies. Those studies came not done by randomized control definition, but coming from the observational studies of the use of this kind of surfactants. So after reviewing all the literature from 2009, we analyzed finally 19. 4 of them were real-world studies and 15 randomized controlled trials. And you can see the results when you analyze the effect of the two most used surfactants. From the real-world studies, you can see that there are no statistically significant differences in terms of death or BPD, or any kind of Ehrlich syndrome. So no differences at all. If we analyze the randomized controlled trials using any dose, you know that the Beractan dose recommended is 100 milligrams per kilogram of body weight. The Poractan is 200, but there are some studies that were using 100. So any dose, you can see that there are no statistically significant differences in death or in BPD, even that the BPD was close to be significant in favor of Poractan. No differences at all in Ehrlich or pneumothorax. And when we compare only those studies using 100 of each surfactant, we didn't find any difference in BPD or death. There was exactly the same with the Ehrlich syndrome or pneumothorax. When we analyzed the effect of these same endpoints, Ehrlich syndrome or pneumothorax, using 100 milligrams per body weight of Beractan and 200 of Poractan, we didn't find any statistically significant differences in Ehrlich or pneumothorax. We didn't find also any difference in death. But when we analyzed BPD, we were close to be statistically significant in benefit of Poractan. But when we clearly define BPD as 28 days of oxygen therapy or 36 weeks of postmenstrual age, we then didn't find any kind of difference in terms of the effectivity of both surfactant in terms of BPD. So in summary, there are no clear difference in between the surfactant. The surfactant you have to use are those surfactants that demonstrated in clinical trials that they are effective and safe for the baby. But when to give surfactant? Normally, we used to give surfactant when the baby is suffering by a respiratory distress syndrome. But how sick should be the baby? And how fast should we have to give the surfactant? So some years ago, we tried to give the surfactant even as soon as possible, even at the labor and delivery room. But now, after some studies, we have enough evidence that stabilizing the lung after delivery, giving enough pressure to give or to help the babies to produce their own functional residual capacity, is going to decrease the number of babies who will be given surfactant. So today, what we try to use is surfactant as a rescue therapy after we stabilize the baby's lung after delivery, but not waiting too much. So normally in the first 1 or 2 hours after delivery, the baby still needs more than 30% oxygen with good pressure support at least 6, and these are the European consensus recommendation of giving surfactant, then is when most of the hospitals are choosing to give surfactant today. But there are some other indication of surfactant. More recently, we are trying to find another kind of indicators to give surfactant to our baby, not only the FiO2 need to stabilize the oxygen saturation. So Rebecca Gregorio from our institution, she is one of the specialized staff in our team doing lung ultrasound, and she published this nice study analyzing the potential effect of using lung ultrasound to clearly select to whom preterm babies you should have to give surfactant. So she did this prospective study. She compared using the ultrasound before and after those babies who need surfactant, or before in those babies who didn't need surfactant, in a population of, you can see summarized in the slide, of around 16 with surfactant before and after, or without 48. So this is the standard lung ultrasound that you can see here. This is the normal lines of the lung. This is the situation where you have, it's called interstitial syndrome. And in this kind of other situation, there is a lot of atelectasia without enough gas in the lung. So this is the typical white lung situation. So applying a score to clearly define the severity of the syndrome by lung ultrasound, and using this scoring system and compare with the FiO2 standard. And this is where the indication when we gave surfactant to our babies, FiO2 more than 30% oxygen, to keep SpO2 in between 90 and 95, and applying this what we call score of severity by lung ultrasound. Normal is from 6 points, and severe diffuse disease is 18 points. So she analyzed very nicely and compared the two groups. The babies who need surfactant because they were sick, and other babies in similar situation at the beginning, similar gestational age, but they didn't need surfactant after because they stabilized quite well with just CPAP. You can see the two group of babies with different situation before and after giving surfactant. You can see the babies who need surfactant were sicker in terms of higher FiO2 from 30 to 44. What we call is saturation to FiO2 ratio much lower compared to the babies who didn't need surfactant. So when we analyze the lung score situation, you can see how the lung score clearly defined those babies who were needing to be given surfactant very nicely, because most of the babies were having score more than 12, in the range of 13 to 18, with a median of 16, compared to the babies who are in the non-surfactant group with very close to normal ultrasound score. So I think these new tools will help us very nicely to select probably earlier than waiting too much to give surfactant to those babies instead of the use of FiO2. And if you see the ROC curve, you can see how this is the classical curve to define sensitivity and specificity of a test. And you can see how the lung score clearly demonstrate a much better sensitivity and specificity compared to the FiO2. So probably this tool is going to be very easy to be done in any hospital, in any situation, because it's easy to learn and easy to apply to the babies because it is non-invasive. So how we give surfactant today? because from many years we try to decrease the number of babies who need to be intubated. We try to give the surfactant in the less invasive therapy as possible. We were using the Insure technique until the late 90s. But at the beginning of this century, the German group described a new technique called less invasive surfactant administration. So this technique consists of just looking at the baby glottis and introducing cannula or a catheter just during a few seconds, and then put the surfactant and apply the surfactant in the bolus or to liquids and give it while the baby is still breathing spontaneously connected to nasal CPAP or nasal ventilation. But what is the evidence today behind the use of these new techniques? So TCA is the new non-invasive or less invasive surfactant administration. And you can see in this meta-analysis published just a few months ago that when you compare with the standard Insure technique or intubation, there is no statistically significant effect on mortality. But when you look at the BPD, there is a trend to benefit the less invasive surfactant administration technique compared to the classical Insure or intubation. Not clearly statistically significant, but when you combine the two endpoints, death or BPD, clearly the less invasive surfactant administration technique is superior to Insure in terms of decrease the number of babies who are going to die or survive with BPD. So we have some evidence behind that this kind of technique at least are similar, but probably better than the standard of intubation or giving the surfactant by Insure. This is very similar with the pneumothorax, no difference with Insure, but with a clear benefits compared to intubation standard given surfactant compared with. And of course, if you don't intubate the baby, the number of babies who need to be intubated within the first 3 days after delivery are much lower. So this is a clear benefit because during the first few days after delivery is when the risk of develop chronic lung disease is much higher. Well, this is the first study that we published some years ago, 4 years ago, using Baractan. This is a doll, and you can see how we introduce the catheter below the vocal cords. And this is the before and after classic X-ray of a baby. This is a 28-week gestation, giving surfactant by LISA technique, less invasive surfactant administration. You can see how nicely the baby's lung improves. This is a real-life video just to show you that the technique is not so far difficult. You have to train, of course, as everything you have to do in intensive care. So the baby is connected to nasal CPAP, is breathing spontaneously, and then we introduce the catheter, as you are going to see now. This is a specific design catheter to give surfactant and approved for giving surfactant. And then once you introduce the catheter below the vocal cords, you take off the laryngoscope, and this is it. You close the mouth, the baby is breathing spontaneously, and then we apply, in this case, the Baractan, 4 ml per kilogram of body weight in one shot. You can see how the baby is breathing while you're giving the surfactant. And after finishing the surfactant application, we just clear the catheter with air to prevent clotting of feet. And then we take out the catheter and the baby is breathing again. So this is the way we use the surfactant. This is the first study that we did. These were the indication, as I told you before, FiO2 more than 30% oxygen to keep SpO2 between 90 and 95. And the first results, when we compare with an historical Insure control group, we found that we had, of course, less mechanical ventilation in the group of LISA compared to Insure, and less number of babies who need to be ventilated during the first 3 days after delivery. And how safety is this technique? So we follow the babies until they were 24 months or post-menstrual age. And we wanted to test how the babies were doing in terms of biological outcome. Of course, the group of babies who were given surfactant by the less invasive surfactant administration were mechanically ventilated less than the other groups. And when we analyze all of the neurodevelopmental milestones, we found no statistically significant between the two groups. So we can say that this technique at least is safe for the babies, and the babies are doing very well in terms of neurobiological development. So finally, I wanted to show you that probably when we are facing a baby with immature situation and respiratory distress syndrome, of course, any point to prevent lung damage is going to improve survival, but there are several things that we have to do to prevent lung damage and improve survival of those babies. So we review our data for two periods before and after 2016, when we began to give less invasive surfactant administration, and we compare the two historical before and after evolution. And as you can see, we not only give more surfactant by less invasive, but also we increase synchronized nasal ventilation. We increase, as we are going to show you in the next talk, high frequency oscillatory ventilation for the sicker babies who were still connected to the ventilator. And we found that doing this whole thing together, we could decrease in a statistically significant way the grade 2 and 3, this is the moderate to severe BPD in this group of babies. So talking about the future is, I don't used to like to talk about this because you never know exactly what is going to happen tonight, even more in the future or in medicine. But of course, probably the use of even less invasive surfactant administration, what is the aerosolized surfactant, is the way probably we are going to work. We are working so far in this topic today. This is the standard membrane vibration Brechtan administration by aerosol. There's some data coming from Dr. Junaid. She's from Michigan. She's doing a very nice job with this kind of aerosolized surfactant. She published this nice study, phase 2 in babies who were given aerosolized surfactant because they were in the risk of developing RDS with high flow nasal cannula or nasal CPAP for nasal ventilation. She compared the before and after situation of the babies given surfactant by aerosol. And in this case, as you can see, babies were doing better, but no, they tolerate very well this kind of surfactant administration. So this is in summary what I wanted to review with you today. Giving surfactant is not the most important thing, but it's a key point in the respiratory support of our babies. But this should be a global approach to the babies to be at least the less invasive as possible, but don't wait too much. If a baby is needing to be given surfactant, give it as soon as they need it. Well, thank you very much for your attention.